Welcome back to Medication Monday.
Hello.
I want to talk about Risperidone.
All right. What you got?
So, when is a patient prescribed this?
Yeah, Risperidone is a very useful medication in psychiatry. It's indicated for schizophrenia, I believe, schizoaffective disorder, and bipolar disorder. And Risperidone is part of a class of medication called second generation antipsychotic. Um, and those medications typically block dopamine receptors and they block serotonin 2A receptors, which helps with preventing something we call psychosis. It also promotes mood stabilization for people with bipolar disorder, and I'll kind of break that down. So, psychosis is when folks hear voices speaking to them that other people can't hear. Um, and that's called an auditory hallucination, or or psychosis can be delusions, like where people feel paranoid, and paranoia is like a fixed false belief that they're being surveilled or somebody's monitoring them, and that can get very severe and be very distressful. So Risperidone helps reverse that and helps folks feel better. In bipolar disorder, we think and we know Risperidone and medications like it help stabilize folks from being like manic. And mania would be that they have boundless energy, their thoughts are racing, they might have increased libido, they may spend more money or money that they don't have. They may not require as much sleep as they usually do because they're just so revved up. And it's not caused, this state is not caused by any other substances like cocaine or, alcohol or caffeine or something. So we use Risperidone in those conditions as well.
Okay. And are patients typically open to taking it?
Yes, but it, patients are looking to their physicians for direction on what their A diagnosis is and B, what is the treatment for that said diagnosis. So I would never expect a patient to know what they need, right? That's what they're paying me for. However, during the informed consent procedure, which means I have to explain the patient's diagnosis to the patient, the alternative to the treatment, the alternative different treatments. So if somebody had schizoaffective disorder and I said, I would like to use Risperidone for you, but we could also use Seroquel. We could also do electroconvulsive therapy, which is sometimes used for these disorders. We could use a mood stabilizer like Lamictal or something, and I might explain the risk and benefit of each one of those. And then also, patient needs to know that they don't have to take anything. They could say, I don't want to take this and decline. So when you say that, are they open to it? I think when they know the risks and the benefits of a medication, they can become open to it. And I'm always focused on getting results and moving the needle for people so that they can live better lives.
Okay. And is this like a medication that you need to build up your tolerance to? Do you start them on a lower dose and then increase it?
Yes. Generally speaking, we like to use lower doses starting medication. And then over time, we raise the dose depending on how much success we're having or not. In someone with schizophrenia, I would be looking for how frequently and how intense are their auditory hallucinations or their paranoia. So the frequency, if it's every day that they're having voices talking to them, that's one metric that I try to squash by using the medication. So if it's, say they're hearing some voices every day and now they're hearing it every third day, then I would possibly raise the dose for them depending on how well they're tolerating the medication. And then if they're only hearing it, once a week, but it's very intense for them, then we might raise the dose as well. But there's other things we can do. Sometimes we use an as needed medication for breakthrough hallucinations. I have some patients where they do well on Risperidone or Risperidone daily, but there will be 2 or 3 times a month that they have some stress that's causing them to have a reoccurrence of the auditory hallucinations. So then I might add either more Risperidone for those days or something else like Haldol, which is a close cousin to Risperidone, in for them that might have more potency. And you might say, well, why don't you use Haldol all the time? And some of the time is, or the answer for that is, some of the other medications like Haldol may not be tolerated daily as well. And therefore you just use them for what I call spot treatment for that patient.
Okay. So I read a little something that patients need to monitor their plasma concentrations. Can you tell me more about that?
Of Risperidone,
Mhm.
no, we don't keep track of the Risperidone levels unless we think someone's toxic, or if we think like there's something wrong with the medication where maybe it's inert, like they got a bad batch, um, or they're like there was an overdose or something, and you need to know, like again, speaking to the toxicity part. So we actually don't check Risperidone level. At least I don't check Risperidone levels for maintenance. There's usually a parameter of a safe dosing schedule of what most patients could take. And we know that from FDA approval and the research of the medication while it was being approved to use for these conditions. So you can look back at that and they can say, well, out of 1,000 patients who tried Risperidone, these were the side effects they had at these doses, usually like 2 to 6 milligrams, let's say. And that's why we don't need to check the levels per se.
Okay, thank you for clarifying that.
Hmm.
That's all I've got for you. And
Okay,
thank you
great.
very much.
Thank you.
Bye.
See you later. Bye bye.